Okay, sir. So, good afternoon to everyone. So, this is Beena Chaudhary. So, I'm presenting today the identification, evaluation, and selection of graft source, and including with the use of donor registries. So, we'll talk about this today. I have some objectives. So, we'll discuss some like introduction about it, like how we are going to select the source of graft and like evaluate all selection of source of hematopoietic stem cells and donor selection with donor registries and how we are using it and what in all organizations are there.
Hello, Bina. Sorry, we could not see
Yes.
your screen. Your screen is
Uh,
not visible to us.
I can see it, Azra.
Okay.
I can see it too.
other people?
No, I can't see too.
Well, that's strange.
So still it's
Nina.
like I have share screen, but I don't know.
I share to all, please.
This is only one option will be there, says to all only, everything. Sir, only you can see or other people also
No,
is there?
also Ali can see it. Hello, Kaveri. Can you see the screen of Bina and Ufika?
Yes, sir. Now I can see.
And Azra? Can you see it?
No, sir. Not yet.
Ajit, can you see it?
Yes, sir. Now visible.
And then Azra, I don't know what to say.
But even I have shared the PPT in meeting, so you can open over there too.
Okay.
I have attached PPT. Yeah. Okay. Shall I
Bina, go
start
ahead.
then?
Yes.
Yeah. So introduction. So first, actually, like there are various sources of hematopoietic stem cells, like in today's world, like we are using. So there are three only, other than nothing. So one is the bone marrow and peripheral blood, and another one is umbilical cord blood. So in hematopoietic stem cells may be obtained from autologous or like allogenic. There will be a match related or match unrelated, some mismatch related or unrelated donors we can find out, and the umbilical cord sources also like is there. So another one is identification, evaluation, and selection of source of hematopoietic stem cells. So clinically, transplantation is currently performed utilizing three major sources, which already I have told now just now. So one is the bone marrow. So it's actually like I have put in little bit in brief in next slide, but like little bit I have put here also. Easy to collect and is still the most widely recommended for the allogenic graft. And the second one is mobilized peripheral blood stem cells that like we can call PBSC. So if we'll use this one, like rapid engraftment will be there and mostly advisable for the autologous transplantation because in the allogenic context, it is associated with more chronic GVSD. And the third one is umbilical cord blood. So which is readily available from the cord blood bank, but it's expensive and associated with the delayed engraftment. Mostly actually used for the children lacking a matched sibling. And for these, actually, there is lots of like it needs lots of extensive quality assurance program to take care of it, these like to collection and storage of the umbilical cord blood. So, and first bone marrow. So we'll talk about advantage and disadvantage about it. So it's golden standard of allogenic hematopoietic stem cells transplantation for 3 decades, like it's almost we are using it. So the advantage of using bone marrow is less T cells in graft compared with the peripheral blood source, and decreased risks of chronic GVSD, and decreased mortality in children and adolescents. And even like we are doing this, but still there are lots of disadvantage. So even it requires operating room with the general anesthesia, and it also increase sometime the morbidity to the donor, some like including pain, infection, blood loss, and the musculoskeletal damage. And sometimes the young pediatric donors, they require blood transfusion. If like for that reason only we are doing the pre-deposit before the transplant, so that during the bone marrow harvest we can give to the donor. And sometimes it can be a slower neutrophils and platelet engraftment, and sometimes it also increase risk relapse in some studies, like some of them. It's not that much. And for the peripheral blood stem cells, has actually largely replaced marrow as a primary source of hematopoietic stem cells. It's like principal and preferred source of all autologous hematopoietic stem cells transplantation products. So in actually, mostly we are using this for the adult allogenic transplantation, and even the pediatric allogenic too, but not that much. In that case, we are like preferred marrow over the PBSC. And advantage of PBSC is like it will recover fastly hemopoiesis compared to the marrow, and it also decrease the morbidity to the donor, and also actually it increase the overall survival rates and the disease-free survival in high risks of hematologic malignancies. And even this also, there are lots of even disadvantage for the PBSC2. So must mobilize the stem cells into a circulation for the peripheral collection. So it needs some stimulating factor like GCSF, GM-CSF, and the Flexa4, like we are using to do this. And the Flexa4 approved for the autologous use only, and more T cells in circulating compared with the marrow. It like issue with the allogenic hematopoietic stem cells transplantation. And this actually the most disadvantage of PBSC is the increase of risks of chronic GVSD. So like because of that, like we are not doing in our setting. So only I think we have done for 1 or 2 patients, not much. Umbilical cord blood. So these, like we can see lots of donors, but that is unrelated, can be identified for like almost 6,000 to 10,000 patients who could potentially benefit for the hematopoietic stem cells transplantation. It's not that particularly true for the minority patients. And typically the cord blood units type at intermediate resolution for the HLA-A, HLA-B, and high resolution for HLA-DR. So there are advantages of umbilical cord blood too. So it can be a criteria for the match less stringent. So there will be 4 out of 6. Also, it can be like good. So umbilical cord blood lymphocytes are less alloreactive, and it also allows for the greater HLA disparity, can engraft with the 4/6 match, and even there will be a less chance of getting GVSD for degree of mismatch. So there is like not much chances for the GVSDs. So even this, like in umbilical cord blood, we have lots of disadvantage. So it needs cell dose that should be need minimum 3 to 4, 10 to the power 8 total nucleated cells per kg to ensure durable engraftment. Only 10% of umbilical cord blood unit have sufficient stem cells to transplant a patient more than 50 kg in the weight. Like sometimes the patient will be more than weight and the like umbilical cord volume, like it will be a very less cell dose. So because of that also we can give to the patient. And it also like slow engraftment related to a related or unrelated donor, and even it increased the infectious complications from slow neutrophil engraftment, because delayed engraftment also increased like lots of infections, and there will be a no availability of DLI, because if it got graft failure or relapse, there will be no like DLI. So there will be a limited inventory available, like in currently it's not that much. I'm clear till now.
Yes,
Yes.
Meena. Yes.
Okay. So these are the stem cell source, like you can see in the image, like peripheral how we are collecting. So and the bone marrow how we are doing, and umbilical cord blood. So these are the images so that we can see like how we are collecting the stem cell source. So peripheral, like will in apheresis machine we can connect with the patient and we are collecting like that. And the bone marrow harvest we are aspirating under the general anesthesia in OT. So this umbilical cord blood, like we'll just collect the placental blood, directly drain into the bag like that. So these are the images. So after this all, like after the selecting of the graft, like even like stem cells, we can call it. So after that also donor selection is very important too. So it is known that multiple factor impact on the transplantation outcomes. Sometimes the heaviest one are disease related, disease refractoriness, phases, clonal abnormalities, etc. in malignancy and disease type, and associated with the rejection risks in non-malignant disease. And the patient-related, sometimes patient is like comorbidities, infectious disease, like these also can like impact on the transplant outcomes. And moreover, donor-related issues and the stem cell source may influence the extent of disease control and the transplant-related mortality. So these are like very important things. The availability of a suitable stem cells graft is an absolutely prerequisite for the performance of allo hemopoietic stem cells transplantation. Beyond donor recipient histocompatibility, other factors such as stem cells, cell sources, donor age, even the gender, donor recipient CMB status. So that also like impact on the transplantation outcomes. Even ABO compatibility may also take important roles for the transplant outcome. So I have mentioned over here the donor selection for the pediatric patients, as we are doing pediatric transplants. So mostly I have mentioned here. So donor selection criteria may vary between like adult and the pediatric recipient according to the motto of the Pediatric Disease Working Party. Children are not a small adult. Beside the size, what makes hemopoietic stem cells transplantation in children different in mainly related with the indication and the biological of growing individuality. So in that also like pediatric recipient size, which like the lower the recipient, the smaller is the amount of the request absolute count in the graft, which makes the harvest easier. Actually, if we talk about the pediatric recipient side and indication, in terms of indications, according to the EBMT nowadays, like in this year, in 46% of patients younger than 18 years who undergoes hemopoietic stem cells transplantation are affected with non-malignant disease, which are mainly inherited disorder, namely actually immunodeficiencies, like lots of things will be there. So because of that indications, like it may vary for pediatric and adults. And another one is donor type. So due to lots of in modern families, actually it's not that much. So actually identical siblings are available in less than 25% of children's in the need of transplant. As the consequences, like almost 80% of patients may need to run a search for a unrelated donor, because there will be a no match of HLA siblings. Because of that, they will go to the unrelated donors to do a like transplant. For haploidentical patient in the pediatric, so of course, like everybody knows, like in our centers, if we'll talk about like haploidentical, mostly we will prefer mother, because due to both reduce in incident of relapse and the TRM with the protective effect on the risk of failure, possibly explained by the transplant, like transplacental leukocyte trafficking during the pregnancy, including long term of, like it also increased like microchimerism in mother and the child. So because of that, like we'll mostly use the mother. And stem cell source, of course, like will use the bone marrow aspiration more than like other PBSC and umbilical cord, because umbilical cord is like we can get more. So because of that, till here I'm clear.
Yes, Bina.
So
Yes,
in
Bina, go ahead.
recent yeah. So in recent survey within the Pediatric Disease Working Party of the EBMT, the features were listed in the following orders, importance and the average, but evaluation widely differ among responders. So like lots of things, HLA compatibility with 10 by 10 better than 9 by 10 or words matching, and the CMB serological status of positive donor in case of positive recipient, and the bone marrow as a stem cell source is very like good, like in our setting, even like other setting also they are using. Donor is being preferable a younger donor compared with an older one, and donor gender with the male donor preferred, particularly for a male recipient, like no mismatched gender. And ABO measure compatibility also is very important, and the donor center location and the ABO minor compatibility also, like it also impact on the transplantation things for the outcome. So till here we have talked about almost stem cell source with the other like donor selection, how we are selecting. And now we'll talk about the donor registries. So as we know, the donor registries is a listing of potential marrow donor and the donated cord blood units. So it's kind of like a donor or a donor will register in like some registry like units and things. The European Bone Marrow Transplantation Groups took the initiative to establish bone marrow donor worldwide, and the bone marrow donor worldwide was generated in 1988 in Leiden, the Netherlands, under the auspices of the Europe Donor Foundation. As of November 25, 1998, there are 5.4 million donors in bone marrow donor worldwide from 59 registries, and the cord blood bank in 34 countries, 2.1 million donor of whom 39% are AB and DR types are from 43 registries, and the cord blood bank in 25 European countries. The large number of individual registries and the multiple transplant centers across Europe underlined the needs for a common telematic system. This is all about the European registries. And in India, actually, the Dhatri is India's largest unrelated blood stem cells donor registry, which has 4+ lakh donors database. Dhatri's mission is to save lives of those suffering from life-threatening fatal blood cancer and the disorder like the blood cancer, leukemia, plastic anemia, sickle cell anemia, thalassemia, etc. like that. These are like registries in India. This is so how we are using these registries. So an unrelated donor or umbilical cord blood search should be initiated to identify donor and the cord blood unit whose HLA type is potentially identical to the patient's. And they will determine the parameter of the search, including the type of search to be performed. That is adult progenitor cells donor, cord blood unit, or both urgency of the search, the specific HLA loci to be considered during matching, and whether or not mismatch are acceptable. These criteria are found in the transplant center protocol. So there. And after that, they will collect the following information about the patient, like HLA typing data, preferable, including the patient HLA haplotypes, and date of birth, diagnosed date, gender, weight, even the CMV status and ethnicities. So after that, like they will perform a search of bone marrow donor worldwide, which provide you with a comprehensive overview of almost all hematopoietic stem cell source worldwide, and complete a search request form and submit the search request form to all the registries of interest, or electronically enter the patient information directly using software or web access where available, and a generic form accepted by many registries and the cord blood bank. So till here, like I've talked about the donor registry, how they are doing this, and what in all the registries were there available in worldwide and even in India, which is working with this. And this actually one like general is there, so it was released on 2020 February. So even if you'll go through this, there like some studies are there, immunogenetic in stem cells donor registry work in like DKMS example. So there also it's like data of how the registries are working and how many donor registers are there available. So everything is over there. So if you wanted to know about it, you can search. Thank you, sir.
Thank you, Bina. I'll make a few comments on this slide. So, so in our experience, of course, Bina, we only use transplantation for non-malignant diseases. And so, yeah, so that's the reason why